Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's May 2024 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice this month is an original article entitled Shock Severity Classification and Mortality in Adults with Cardiac, Medical, Surgical, and Neurological Critical Illness. It is authored by Dr. Jacob Zenzer from Mayo Clinic in Rochester, Minnesota, and colleagues from Mayo Clinic in Rochester, Minnesota, Jacksonville, Florida, and the University of Alberta Hospital in Edmonton, Alberta, Canada. Shock, defined essentially as a state wherein the demand for and consumption of oxygen exceeds the supply of oxygen, is commonly a driver of mortality in critical illnesses. While often cardiogenic in origin, other types of shock includes those that are distributive, hypovolemic, or obstructive. Not uncommonly, the basis for shock may involve more than one of these pathogenetic processes. In their current study, Zenzer et al. Questioned whether a particular classification of shock, the shock classification of the Society for Cardiovascular Angiography and Intervention, abbreviated SCAI, may be broadly applicable to critically ill patients in general. The basis for their question and study is that while the SCAI shock classification has performed persuasively in multiple studies of mortality risk stratification, this classification was developed and introduced for patients at risk of cardiogenic shock. To address this question, Zenzer et al. Studied more than 20,000 Mayo Clinic intensive care unit patient admissions that involved cardiac ICU 16.7%, medical ICU 37.4%, neurosciences ICU 27.7%, and surgical ICU 18.2%. The SCAI shock classification involves one of 5 stages and was determined in each 4-hour period of the first 24 hours of ICU admission. The 5 stages of this classification include no shock A, hypotension tachycardia with no hypoperfusion B, hypoperfusion C, deterioration D, and refractory shock E. The data demonstrate that there was a stepwise increase in in-hospital mortality in each higher SCAI shock stage for the entire patient population, as well as for each distinct ICU subtype. The functional risk stratification was generally more effective for medical critical illnesses, that is, cardiac ICU and medical ICU admissions, compared with surgical critical illnesses, that is, surgical ICU and neurosciences ICU admissions, with the best performance for cardiac ICU and the least effective for neurosciences ICU. Zenzer et al. Point out differences between medical and surgical critically ill patients that may explain the greater prognostic efficacy of the SCAI shock classification in the former patient population. And these include the following. First, even among surgical patients with stage E shock, their illness and shock were less severe compared with similarly staged medical patients. Second, surgical postoperative stress may more likely resolve. Third, non-cardiovascular contributors may be more influential in surgical patients. And fourth, circulatory failure is an uncommon indication for admission to the neurosciences ICU at Mayo Clinic. Salient conclusions of this important and timely study of Zenzer et al. Are that beyond established prognostic markers, the SCAI shock classification provides incremental mortality risk in a heterogeneous patient population that encompasses the broad range of medical and surgical critical illnesses. Additionally, this classification may serve as a lingua franca in discussing patients at risk of or with shock. And finally, this classification may have wide applicability in evaluating shock in general in critical care and in such areas as decision-making, practice, and research. Our first highlight article this month is an original article entitled Hospital Outcomes in Medical Patients with Alcohol-Related and Non-Alcohol-Related Wernicke's Encephalopathy. It is authored by Dr. Roshani Rasia from the Cantonal Hospital Aarau in Aarau, Switzerland, and colleagues from the University of Basel in Basel, Switzerland, and Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Caused by thiamine deficiency, Wernicke's encephalopathy is often described by the triad of encephalopathy, ataxia, and oculomotor dysfunction, a triad observed, however, in less than 20% of patients. When thiamine is expeditiously administered, this condition may be reversed. The vast majority of cases of Wernicke's encephalopathy are due to thiamine deficiency caused by alcohol use disorders. In the minority of cases, it may be due to insufficient dietary intake of thiamine, for example, anorexia nervosa, by gastrointestinal loss of thiamine, for example, by inflammatory bowel disease or hyperemesis gravidarum, or avid tissue consumption of thiamine caused by such conditions as cancer and the refeeding syndrome. Awareness of the disease, promptly diagnosing it, and swiftly treating it are all of the essence. Rasia et al. Assessed the causes and consequences of Wernicke encephalopathy in a population-based retrospective cohort study that used in-hospital claims of patients diagnosed with Wernicke's encephalopathy. Of the 4,393 hospitalizations that occurred between January 1, 2012 to December 31, 2020, 93.3% were alcohol-related, with the incidence rates for hospitalizations being 14-fold higher in alcohol-related Wernicke's encephalopathy. Increased rates for hospitalizations were observed in relatively younger patients beginning at 40 years for alcohol-related Wernicke's encephalopathy, but in non-alcohol-related Wernicke's encephalopathy, such rates were increased in patients who were 65 years or older. Both types of Wernicke's encephalopathy were more prevalent in male patients. Alcohol-related Wernicke's encephalopathy compared with non-alcohol-related Wernicke's encephalopathy exhibited a higher risk for the development of Korsakoff syndrome and a higher rate of one-year hospital readmission, but a substantially lower in-hospital mortality. As suggested by the authors, the higher in-hospital mortality in non-alcohol-related Wernicke's encephalopathy likely reflected more serious underlying illnesses and/or that such conditions were not diagnosed and treated as promptly as for alcohol-related Wernicke's encephalopathy. The higher incidence of Korsakoff syndrome and alcohol-related Wernicke's encephalopathy may reflect the additional adverse neurologic effects of alcohol itself, while the challenge of effectively treating alcohol use disorders may underlie their proclivity to higher one-year hospital readmission. This important study by Rasia et al. Delineates significant differences between alcohol-related and non-alcohol-related Wernicke's encephalopathy, but for either, as emphasized by the authors, the commonality and centrality of expeditious replacement of thiamine is an overriding therapeutic imperative. Our second highlight this month is a review article entitled Acute and Complicated Inflammatory Pericarditis, a Guide to Contemporary Practice. It is authored by Dr. Awais Malik and colleagues from Mayo Clinic College of Medicine in Rochester, Minnesota. Acute pericarditis is a relatively common condition, accounting for some 0.2% of all hospital admissions and 5% of emergency room visits for chest pain not caused by cardiac ischemia. Pericarditis more commonly afflicts young males. Malik et al. Begin their comprehensive review of inflammatory pericarditis by discussing the epidemiology of this condition, its etiologies, and the risks for recurrent disease. Clinical and relevant laboratory findings that point to the diagnosis are reviewed, followed by the diagnostic utility of the ECG, the transthoracic echocardiogram, cardiac computed tomography, and cardiac magnetic resonance imaging in establishing the diagnosis. Malik et al. Discussed the spectrum of therapeutic approaches for acute and recurrent disease, and this includes nonsteroidal anti-inflammatory agents, colchicine, and glucocorticoids, and newer therapies that specifically target interleukin-1, IL-1, such as the competitive IL-1 type 1 receptor inhibitor, and IL-1 alpha and IL-1 beta cytokine traps that bind circulating IL-1. The manifestations of constrictive pericarditis and its management by pericardiectomy are discussed, the latter also indicated in some settings for recurrent disease. Adjunctive therapies such as pericardial drainage, intrapericardial corticosteroids, hemodialysis, and beta blockers may be needed for certain complications or causes of pericarditis. The diversity of microbial causes of pericarditis is outlined along with relevant therapeutic approaches. The authors also discuss the extension of pericarditis to myopericarditis and the occurrence of pericarditis in pregnancy, COVID-19, and in rare autoinflammatory diseases such as IgG4-related diseases, among others. This article by Malik et al. Is a superb overview of the assessment and management of a relatively common disease that may occur as a single episode without sequelae, may progress to challenging, incessant, recurrent, or chronic disease, or culminate in major complications very much in need of expeditious attention. You can access these highlights and editor's choice articles free of charge during the entire month of May. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage based on articles published in Mayo Clinic Proceedings. You will see other free content as well as articles published online in press. You will also find links to our social media by clicking the buttons at the bottom of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and author insight podcast recordings, which are available from our website on our homepage as well as through iTunes. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research. All rights are reserved, including those for text and data mining, AI training, and similar technologies.